Real happy to be here today. So I'm a radiation oncologist from Mayo Clinic in Rochester, Minnesota. And I want to talk today about esophagus cancer. And really I want to focus on a few things, which is one, the aging population. So some of the geriatric component of esophagus cancer. But also some tips too on conformal radiation as we move towards from two-dimensional to three-dimensional radiation treatments. And I have no financial disclosures to make. So by way of outline, I want to talk about the incidence of esophagus cancer, really hone into that of Africa. I also want to talk about the incidence based upon different age groups. We're seeing an increase in the elderly population of esophagus cancer. And with that, I'd like to talk about some research we've done within that patient demographics to look at outcomes for elderly patients with esophagus cancer. And then lastly, I'll talk about some DVH and organs at risk information in regards to esophagus cancer. So this is data we've already seen a bit today, so I won't spend too much time on here. But looking worldwide at esophagus cancer, we see it's more common in males within the top 10 in the world. But we do see its a mortality rate is one of the top 5 or so cause of mortality for patients with cancer. If you look at estimated new cases and mortality in patients in developing countries, we see a higher incidence of esophagus cancer and a high ratio of mortality as well. And this shows you the general incidence of esophagus cancer in males throughout the world. We certainly see there's certain areas within the Asia and as well as Eastern Africa with higher incidence of esophagus cancer. And a similar picture with a lower incidence overall for women with esophagus cancer. If you look at the estimated incidence and mortality, and this is a comparison looking at developed countries versus developing countries, we can see higher incidence and mortality rates in worldwide and developing countries. And this is true for both genders, both male and female. I want to focus now on Africa data, and a lot of this came through GlobalCan and other resources. We can see that the geographical trend for incidence matches that of mortality quite strongly. And this is data from 2012. There are projections of what trends will be over the next several decades up to 2035. And the projections are similar to that in the United States, which is an increase in esophagus cancer in both genders. But in particular, what I want to focus on a bit today is we can see the rise in patients over the age of 65. If you plot out estimated incidence as well as mortality, we can see that younger patients, which is the incidence of the blue line on the top, is, as well as the mortality, which is the, sorry, I'm trying to not seeing is the light blue. You can see there's a big gap between incidence and mortality for younger patients, whereas in elderly patients, the lines are almost one and the same. So as a brief summary, 80% of all cases of esophagus cancer occurs in less developed regions. There's a preponderance of male patients, about 2.4 to 1 as a ratio. There's large geographical variations of esophagus cancer with even 20-fold differences of incidence within Africa, with less than 1 per 100,000 in Western Africa and greater than 7 per 100,000 in Eastern Africa. Survival is overall poor, and mortality rate reaches incidence at about 0.9 ratio. So I want to pause for a bit and look at some data from the United States as well. And this is a series analysis of a decade or so of patients. And similarly, we can see that about 50% of patients in the United States are also above age 65. And we can see that's a trend that's been going on since the 1980s and continue to rise into the 2000s. Within the United States, the highest growing incidence is actually in elderly patients above age 65. So I hope to extrapolate a bit from this patient population of elderly patients and give data we've learned, lessons we've learned from treating elderly patients with esophagus cancer. So once again, looking at US patients, and I'm not going to go much into the technical details of treatment for patients, let alone to say that chemoradiation followed by esophagectomy is considered the standard of care within the United States. Despite that though, looking at a 10-year time period, only 7% of patients over the age of 65 actually receive trimodality treatment. So within the United States, there appears to be a lack of standard of care treatment for patients who are considered elderly. And in a variety of studies, the operative mortality for patients who have esophagus cancer has ranged from 4% to 13%. So a few challenges I'll talk about in regards to esophagus cancer specifically is the rising population of elderly patients with esophagus cancer, representing close to 50% of patients. And this is a unique population. There's more comorbidities. There could be differences of tolerance to treatment. And we have to look closely too to the oncologic outcomes they can handle based upon their treatment tolerance. The other challenge is organs at risk. And this is a figure below from a breast cancer study showing that the risk of treatment-induced heart problems increases based upon the risk factors that patient has for coronary artery disease and exposure to radiation to the chest. In esophagus cancer, here's an illustration. And on the far side, we can see the tumor outlined in a red. That's a distal esophageal carcinoma. And the pink is the outline of the heart, just adjacent to it. And if you look at the PET scan, you can see the hypermetabolism within the tumor, indicated by the middle arrow, and with the hypermetabolism of the heart just adjacent to it. And this particular patient is also very challenging that there's a mediastinal lymph node up top, as well as a paragastric lymph node below. So to treat this patient, as you can imagine, you'd have a massive volume of heart and lung receiving high doses of radiation. And that becomes a difficulty when you treat these patients, is do you have the radiation enter predominantly through the lung, sparing the heart, or predominantly through the anterior and posterior, sparing the lungs? And decades recently, many people had done radiation more on the lung sparing with concerns for post-operative pneumonitis and ARDS and other complications, thinking that that may be the most important thing is preserving the lung function for a presumed surgery. But we're seeing more and more data coming up that's showing that there are acute heart events that can happen as well, and I'll show you some details later on in this talk. I think it's also very important to keep in mind the therapeutic ratio. And as we increase our chance of tumor control, the probability of major treatment complications rises as well. But I think the other component too is the potential of tumor symptoms. So the lack of tumor control can cause significant morbidity and mortality for patients as well with esophagus cancer. So I want to address a few things first, and the first being the aging population, looking specifically at outcomes for these patients. And as you recall, within the United States, only 7% of patients above age 65 received what is considered standard of care radiation treatment. And I'm going to do this based off of some data that we published, which is a combination study from Mayo Clinic, MD Anderson, and University of Maryland. We had a pool analysis of about 570 patients with esophagus cancer. And we specifically looked at patients dichotomized based upon age, so 65 and above or younger. And you can see the spread of patients that we've treated, with about 50% being above age 70 and the maximal age of 88. If you look at overall survival for all patients, as expected, we can see that elderly patients have lower survival. And we actually, I'll put in a slide here, or a picture of the 75 and above too, to put that as a reference for the more extremely elderly patients. But if you look at freedom from esophagus cancer, and this is basically freedom from any local, regional, or distant relapse of cancer, that the lines are very similar. There's no statistical difference, included the patients of 75 and above. And if you look at the same metric with inclusion of overall survival or disease-free survival, we can see that elderly patients have similar oncologic outcomes as do the younger patients. Now, the aging population does have higher incidence of significant comorbidities. If you look at specifically these patients, we see almost doubling of some of these, including hypertension, diabetes, coronary artery disease, prior history of heart surgeries. We do see that the elderly patients do have less current smokers or large alcoholic intakes, perhaps indicating wisdom with age. Now, tolerance to treatment is a big question, and that's really a judgment one has to do in the clinic when you see a patient. And these patients all went on to get chemotherapy with radiation, followed by surgery. If you look at the chemoradiation toxicity, this is upfront treatment prior to surgery, and this roughly has about 4 to 6 weeks of follow-up afterwards. We do not see any substantial difference between grade 3 toxicities between the young patients and the elderly patients, indicating that elderly patients are able to undergo similar treatments as younger patients. If you look at post-operative complications, This is a spline curve with the lower axis showing age and the far side showing the odds ratio of post-operative pulmonary complication. And you can see that as age increases, the potential of a pulmonary complication after chemoradiation related to surgery increases as well, with the odds ratio of approximately 2 per decade of life. Now, the potential of a post-operative cardiac event also increases with age, and this is more of a linear scale. So for every 10 years of life, the potential of a post-operative heart complication is about 1.6 times the previous decade. Elderly patients also have a higher probability of post-operative mortality. In our particular study, it was 5.4%, whereas younger patients had a potential risk of 2.2%. If you reference that to the Dutch cross-esophageal study, which had a rate of 4%, we can see that a 5 or 2% risk is within line of clinical standards and appears to be an acceptable rate for these patients. So if you look at the difference in elderly and younger patients, we can see that one, their cancer outcomes are very similar. We can see that patients that are elderly can tolerate chemotherapy and radiation and be treated with standard of care treatments. But we have to keep in mind that they do have more comorbidities and more susceptible to treatment-related complications, predominantly of heart and lung. Now, I want to show a few things here with the limited time available, looking at organs at risk and what to think about as we move forward to 3D conformal treatment for patients. I have here a slide showing a dose wash of radiation dose distribution looking at 3D conformal. There's IMRT and proton beam. And I'm doing this only to show you the next slide, which seems to indicate the potential of toxicity for this treatment decreases with the more conformal treatments we deliver. In other words, 3D conformal treatments at a higher rate than that of proton therapy, which we think is really related to the sparing of the heart and the lungs, suggesting these are very critical organs to protect during treatment. And this is true for both pulmonary side effects as well as cardiac side effects. Now, if you look at expert consensus guidelines on what to limit the heart and lung to, I think a good example would be the current trial RTOG 1010. And here on the upper corner, I have the metrics that are per protocol or as designed in the clinical study. The bottom two graphs show the close to 700 patients we included in our study. And it's actually a distribution, which I see is hard to see in the back, but it goes from 5,000 centigrade on the bottom to 500 centigrade to the left. And you see the range of doses that were achieved based on percent from 0 to 100% on the far left. I put looks like orange, an orange box outlining patients who actually met the RTOG guidelines. What you can really see is that a lot of patients did not. And in fact, those recommendations are actually very challenging to meet. Now, let alone this is both IMRT, 3D conformal, and proton treatment, but it does show that are these achievable standards? Are these things we can actually target? And are these the appropriate metrics to look at potential complications for patients? And the other important thing too, be going forward, moving into more of a 3D conformal treatment, is how do we adopt these type of standards, and is this the appropriate way to begin with as well? Interestingly, if you look at heart dose, and the top box shows the heart dose, almost every isodose line exposure we see to the heart on univariate analysis predicted for a potential heart complication after surgery. However, in the lung isodose lines, we did not see that same predictive ability, potentially indicating that the heart is one we should maximally spare with radiation treatment, but further studies are needed to validate this. In particular, the heart volume receiving 30 gray appeared to be a very important metric, which I'll show you in a slide. But we included this in a multivariable model, also taking into account comorbidities the patient has, their age, tobacco use, and the type of chemotherapy. We can see that the volume of the heart receiving 30 gray was a predictive metric of heart complication or lung complication following completion of treatment. Now, if I go back and I pull up that same distribution of heart dose on the patients we analyzed, and again, that's the box is the volume of 40 gray to the heart, and that's the metric served by the RTOG as a acceptable range of radiation dose. On the bottom are the same spline curves based upon heart dose exposure and odds ratio of heart event after, after surgery. I put a star on each line where it's an odds ratio of 1. Presumably beyond that point would potentially increase the risk of a heart complication for the patient. Then I plotted the star in each of the distribution of radiation dose. And you can see that if we were to look at the odds ratio of 1, the vast majority of patients in the volume of 40 gray would not have met that constraint. So what I'm getting at is we have different ways to analyze and look at, but the bottom line is I don't think we have the best metrics in which to treat a patient and reduce their risk maximally to prevent cardiopulmonary toxicity. I think much more work needs to be done in that situation. But we can summarize, and this data is still moving forward and ongoing. We can note is that the heart seems to be very sensitive to the amount of radiation exposed to it. And really any isodose line was a predictive metric of heart complications down the road. The pulmonary complications did not seem, but pulmonary isodose lines are not as predictive of complication afterwards. But what when you look at in the heart is the mean dose, the volume receiving 30 gray, 40 gray, or 50 gray is yet to be determined. I think further studies are needed and underway to determine that further. So we are currently looking at the data we have here, trying to analyze the odds ratios of complication to come up with recommendations that one can treat with a 3D conformal plan that would help minimize at an appropriate level side effects for the patient. We really have to keep in mind, as I've learned a lot from this conference, the availability of radiation therapy and 2D planning and moving toward 3D planning as well. So I think a lot of this has to be applied in what can be done with the available resources we have as well. So just to summarize overall, the incidence of esophagus cancer is on the rise. We're seeing more and more of it. We're also seeing more elderly patients with esophagus cancer. And these patients come unique to us with more comorbidities and potential intolerances to treatment. We have to keep in mind the dose of their heart and dose of their lung and helping reduce as much as we can the potential long-term complications for these patients. And with that, I'd be happy to take any questions.